this is a sort of summary of overview of what I'm going to talk about for the elbow part first of all. So how do you assess the elbow MRI scan in a structured way? So we start off looking at alignment, whether there's any fusions, whether there are any loose bodies. Look at the medial structures, look at the lateral structures, anterior, posterior, look at the articular surfaces, and then look at the surrounding bones, muscles, vessels, nerves, and then a few other little bits and bobs. So the first thing is to assess the alignment of the elbow joint. We need to see congruent ulnar side, so ulnar humeral, and then radial side, proximal radial ulnar joints. We need to see whether there's any anterior or posterior subluxation or dislocation of the elbow. Usually it's post-traumatic, so that you're not going to miss that easily. We need to see if there's any varus or valgus instability. That's usually due to collateral ligament injuries. And then we assess for proximal radial ulnar subluxation or dislocation, which is an injury in children, the so-called pulled elbow. And we need to assess the carrying angle or the humeral angle of the elbow joint. That's more or less a clinical assessment. We're not going to see that on MRI because we concentrate on the joint itself, so we don't get an overview of the whole arm as you would in this sort of diagram here. Some normals here. There are slight differences in men and women, but actually it's very, very minor. So I'm not sure that the differences are particularly important. Okay, so there are a couple of pitfalls to looking at an elbow MRI scan. The first is that if you look at this sagittal view, the articular surface on the humerus doesn't go a full 360 or 270 degrees. It only really is here at the front, and therefore at the back, excuse me, at the back there is no articular cartilage. And if a coronal slice goes through that posterior part of the humerus, it can look as if there's a defect in the articular surface. So just beware of where you are. There may not actually be a defect, even though on the coronal scan it might look like there is one. And the other pitfall is if you look at the ulnar articular surface, it's actually two surfaces with a non-articular bit in the middle, which if you look at it on a sagittal, it's not that obvious, to be honest. If you're going through this midline slice, you might see that there and say, oh, what is that? Is that a loose body in the joint? But it isn't. It's just this non-articular ridge that you're seeing. And it really does look very abnormal there, doesn't it? But it is a pitfall. So the joint effusions, I basically classify them as small, medium, large. I'd call this a large joint effusion. So the bright stuff here is the fluid, excess fluid in the joint. And if you look, this is a fat suppressed image. So this little triangular fat pad sitting here outside the joint capsule anteriorly is black. And there's a little bit of fat pad showing posteriorly as well as slightly as black. And if you have a joint effusion, those are pushed out forward and backward because the joint is bulging. So normally they're hiding in here and in here. They're almost, congruent with the bone, with the articular fossae. But when there's a large joint effusion, they're pushed outwards, forwards and backwards. That's why on a plain radiograph, you have something called a fat pad sign. You can just about see a little triangular lucency there and a slightly more elongated lucency at the back. What that is telling us that there's a joint effusion bulging this elbow joint, and that fat pad should be hidden under here. The posterior fat pad should be hidden inside here. So that's the sign on a plain radiograph that you've got a significant joint effusion. Is that important? Well, if you took A&E radiographs in an acute injury patient arriving in the A&E department and you saw that sign, you need to take that patient seriously because they may be an acute joint effusion or, in other words, an acute hemarthrosis. So even if you cannot see a fracture, and look at all this overlapping of the bones. An elbow joint, no matter what radiograph you do, there will be overlapping of the bones. So sometimes a fracture is actually quite hard to see, particularly if there isn't any significant displacement. So the rule is, if you see the fat pad sign, if you see a joint effusion on an acute radiograph, take it seriously because there may be quite a significant injury. So if you cannot see a fracture, can't see a significant injury, the casualty officer, the house officers are taught that they don't just say to the patient, I can't see any fracture, go away. They say to the patient, I can't see any fracture. If your symptoms don't get better, come back. And if they come back and they still look like they've got an acute injury, then repeat radiographs are done, perhaps with obliques of the radial head to try and find an occult fracture that wasn't seen the first time round. Okay, and then loose bodies. So again, we've got a fat pad, two fat sat images. So in other words, the fat has been turned black. So anything bright on these images is joint fluid, And then in the fluid here, you see some loose bodies sitting in there. They normally lodge in the olecranon or coronoid fossae. So olecranon fossa at the back, coronoid fossa at the front. They normally get stuck in there, but they can cause a physical block to full extension, for example, or flexion. Okay, then we're going to look at all the ligaments and tendons around the elbow joint. So start with medial anatomy. So start on the medial side. On the humeral epicondyle here, you have the common flexor tendon attachment here. And that will then come down and attach onto the joint capsule. That will then go down to attach the different muscles further down. The ulnar collateral ligament of the elbow joint has its attachment just distal to the common flexor tendon. And then here on the sublime tubercle of the ulna. That's the same. Now we're looking at lateral there, aren't we? That's those two. Ignore those two for the moment. We'll come back to those. And that's a diagrammatic representation of the ulnar collateral ligament. There are three bundles. There's an anterior bundle, there's a transverse ligament, and there's a posterior bundle. The anterior bundle is the strongest. The transverse bundle here partly forms the floor of the ulnar groove, and then the posterior bundle rest of the floor of the ulnar groove. And if you have, so this is what they look like on the coronal images. So you follow it down on successive coronal images from anterior to posterior. And on the most anterior visualization of it, this is the ulnar collateral ligament. You are allowed a little bit of fat signal within it more proximally where it attaches to the humerus. Don't forget, all ligaments, all tendons should be black on all image sequences. If it's not black, suspect an abnormality. And then as you move very slightly more posteriorly, you then see the transverse bundle. They just seem to merge into one, so it is not as easy as on my diagram to separate these. And then there's the common tendon attachment there on the humerus just above or proximal to the ulnar collateral ligament. Here's the other side common tendon attachment on the lateral humeral epicondyle. And here's a diagram of the posterior band of the ulnar collateral ligament. Here, this one's quite ill-defined, perhaps a little bit thickened, suggesting an injury. That one looks a little bit more normal distally, but perhaps thickened more proximally. So that's one that's or two different patients with injuries. On the radial side here, this little triangular structure is a synovial fringe. You do see synovial plicae bands in the knee joint as well. They're just embryological remnants that haven't completely resorbed. They're supposed to disappear in most people. But this synovial fringe is quite common. And as long as it's not very thick, as long as it doesn't seem to be causing snapping or cartilage erosion, then it's just a normal structure and basically to be ignored. On that last diagram, what I didn't point out was the lateral ulnar collateral ligament. So obviously you expect the ulnar collateral ligaments on the medial side, but there is something called a lateral ulnar collateral ligament. So how does that work? Well, it's called an ulnar collateral ligament because it attaches distally on the ulnar, but it comes from the lateral side and goes behind the radial neck and then attaches to the ulna just below the head of the radius. So here's a injury of the ulnar collateral ligament, ill-defined, a little bit of increased signal proximally, distal attachment is intact, but there is bone bruising here within the ulna. That bright signal, fat suppressed image, marrow should all be dark, but this is telling us there's edema. There's been impaction here you can see marrow edema on both sides of that joint. And that's a partial tear. You can see the deep surface is discontinuous. The superficial surface is intact. Okay, so common flexor tendon sprains. So you see, compared to that last image I showed you, there's a lot of bright signal in this common tendon attachment on the humerus, very, very bright, and it's thickened. So that's a grade 2 sprain. Golfer's or pitcher's elbow on the ulnar side, on the medial side. Now, looking at normal anatomy on the lateral side, so radial side, so we have the common extensor tendon attachment on the humeral epicondyle. Just distal to that, we'll have the lateral collateral ligament, so that's the one that will come down to attach on to the ulna just behind the radial neck. And on lateral view, you see it down here. And then the annular ligament, which is this blue, and it goes round the head of the radius and attaches at the front and at the back on the ulna. So it forms a little pulley around the radial head. We also have here shown where the brachialis and biceps tendons attach on the ulnar anterior surface and the radial tuberosity. We'll come back to those. Triceps attaches at the back on the olecranon. So here's a diagram of the attachments on the lateral side. So the radial collateral ligament, nice fan-shaped band here. The lateral ulnar collateral ligament going round to attach onto the ulna, and then the annular ligament forming a pulley around the radial head. And these are the lateral side ligaments demonstrated on an MRI scan. So there's the common extensor tendon. This structure here, nice and dark. Underneath it and attaching more distally is a lateral collateral ligament under there. And then the ulnar collateral ligament, you're just catching the distal part of it behind the radial neck here, this dark structure. And the annular ligament is this dark line you see here. Quite hard to spot because you only ever cut through a thin slice of it because it's a circular structure. So any plane you look at, you're only going to see a very thin slice of it. So it's probably under here, this dark structure. There it is again on that dark. It's outlined more by fluid here in the joint. And note that non-articular notch at the back. It's normal, not abnormal. So an example of a complete tear of the radial collateral ligament. So there's the common tendon, and then the radial collateral ligament is just, it's gone, it's invisible, it's not under there. But you've also got separation, widening of the radial, of the lateral side of the joint, so varus instability of the elbow because of that ligament tear. And here's some MRI depiction of the annular ligament. So got a lovely axial slice here. We can see most of the ulnar annular ligament, as that dark thin line going around here. And there on a T1 or proton density image as well. The long tendons are demonstrating a fibrous sheath which attaches to the biceps, distal biceps tendon, which is just coming down here. It's under here, and then it will come down and attach on the radius. So we've got here a sprain of the common extensor tendon. You see that bright signal? This is thickened, and there's bright signal in the middle of it. The more common epicondylitis, lateral side, the tennis elbow, and these are all examples of, I think these are meant to be three different patients with grade 2 sprains. And we're looking at that synovial fringe I mentioned before here, and these are three different pictures demonstrating the same structure. It's a normal variant, normally completely asymptomatic, but if it becomes thickened, you can get snapping. And can you see here that this grey on top of the bone here is the hyaline cartilage, and it's thinned from here to here. It's thinner than over here, so that's beginning to be thin, beginning to be damaged. So throwing injuries, the elbow can go into quite abnormal positions in some of the sports injuries, and valgus strain is one of those things. Thrower's elbow or pitcher's elbow, and what you will get is you get medial side tension, so pressure, compression forces or distraction forces this way, which then causes compression on the lateral side. And then if you look at it from behind, the olecranon may impinge on the medial side of the humerus, and then you may get damage here as well. So valgus overload syndrome, and these are examples. So you may get lateral side osteochondral damage. So there's a osseous fragment there separated from the humerus. Medial tension may give you an ulnar collateral ligament tear, and posterior shear injury here on the humerus that we showed you diagrammatically, which could cause osteophytes and OA in the end. And if it does that, you may get osteophyte like this. There's a joint effusion or joint fluid inside the joint here, and the ulnar nerve sits just outside here on the ulnar groove, and you may get impingement by this osteophyte on there and therefore get ulnar neuropathies. And I think this is the same injury or similar injury which is giving you radial side damage, because of the compressive forces on the radial side. The X-ray showing you some lucency there in the lateral humeral surface capitellum, and there's some osseous osteochondral abnormality, bone bruising underneath. And this is a patient who had posterior dislocation injury. It's now, I think it's been reduced, but you're left with evidence that the patient did have an acute dislocation. So you see bone bruising within the posterior aspect of the humerus and the anterior aspect of the radius. So that had impinged on that at the back. So this had been dislocated backwards. You can see that on the coronal image, and you can see that the radial collateral ligament has been injured because you've got widening of the joint space here. And you can see probably an osteochondral injury just there on an axial scan in the radial head. This is an example of a different condition, synovitis within the elbow joint, so that you've got a joint effusion and you've got these little dark, almost separate bodies, which is hypertrophic synovitis. It's marked thickening of the synovium, and it forms like sort of villus formation. And so as the synovium hypertrophies, it forms little villi, and then those villi outgrow the blood supply to the synovium, and they can actually fall off into the joint space. And that's known as rice bodies. Thankfully, we don't see them very often nowadays because we're much better at diagnosing and treating rheumatoid arthritis, but this was a huge issue in the past, and if you like, not a common, but a classical radiological finding. So those are rice bodies. It's just synovitis. You've got a joint effusion. You've got a bit more synovitis in here. Synovitis, remember, shows as grey material, soft tissue in a joint effusion. So obviously it can occur in any joint, but this is an examples in the elbow joint. And this patient has got erosions and synovitis and the joint effusion, so fits with rheumatoid arthritis. So-called little leaguer's elbow. It's a US example of US sport, and you've got a bony avulsion fracture of the medial humeral epicondyle. So you've got bone bruising. That's the fracture line there, and you can see it there on the axial image. Normal lateral collateral ligament just visible here on the radial side on a sagittal view. Triceps tendon, because we've got an extended arm when we're doing this imaging, it looks rather lax and wavy, but that's just because we haven't got a flexed arm and we haven't got that triceps under tension. And then here at the front, we're seeing the biceps muscle, and then the tendon coming down. This is a distal biceps tendon, attaches onto the radial tuberosity here. That's a nice normal looking tendon. Looks a little bit grey here, but we may just be cutting through it partially and maybe seeing some fat outside it, giving you that appearance, but that's meant to be a normal tendon. And I'll show you some abnormals in a minute. The others, so here we go, biceps tendon. So these are axial images. We're starting at above the elbow joint and then working our way down. So well above the elbow joint, there's a bit of the muscle, distal muscle, and the tendon is this dark structure just beginning to form. And then as you come down, the next slice down, you see the biceps tendon there. There are actually long and short heads still visible here at this level. And then as you come further down, there's that fibrous sheet called the lacertus fibrosus that I showed you before. So that's still biceps tendon coming down. Now this is a brachialis muscle on the radial side, and the tendon of forming here. So the on the ulnar side. So the biceps tendon will come and attach onto the radial tuberosity. That's the most distal part of it. And the brachioradialis will attach onto the ulnar side, ulnar. So we're just following these two structures down to their attachments to make sure they're intact. If we're looking for a distal biceps tendon injury, quite important to try and diagnose it early, because if we're going to try and get a surgical repair done, it needs to be early. There's no point trying to do a surgical repair after weeks or months when the tendon has been retracted and there's scar tissue. It's going to be a very difficult operation. They're not going to get a good result. So assessing whether or not a patient has got an acute biceps avulsion or tear is, if you like, an MSK emergency. That's where you really want to get that patient into the scanner as soon as you possibly can. And in that clinical situation, which is quite obvious, you see the tendon is probably torn because it's retracted, giving you a bulge of the actual biceps muscle, the so-called Popeye sign, big bulge of the biceps. And then you get bruising more distally where the tendon's been avulsed, you've had a hematoma. So clinically, very obvious, but what the surgeon wants to know, is it a complete tear? Is it a partial tear? Is there a bony avulsion? So that he can work out how best to treat this patient. If it's a partial tear and there is still some continuity of fibers, he may not opt to do a surgical repair. He may decide to leave it. If it's a complete tear, then the only way he can repair it is to do it quickly. So that biceps view, what I was going to tell you about was this is the position that the radiographers will want to get the patient into. This is the injured arm. So why is it called a FABS view? Because it's flexed elbow, shoulder is abducted, AB, and the forearm is supinated. So it's FABS, FABS view. Once you get the hang of it, it's actually quite easy, and the images are really good because you should see this in a single slice, the whole of the biceps tendon. Here it comes and attaches to the radial tuberosity here. There's the muscle, so that one is completely intact. There's no abnormality. And then here's one that's completely torn. So we've got the radius here and here. There's just hematoma where you should be seeing the distal tendon attaching. And more proximally, here's the tendon all bunched up. It's been retracted from here to here. There's a little bit of hematoma up here as well. And you'd probably get a Popeye sign up here. And here's another view of it. It's come from here all the way up to here. So there's huge retraction. And you can feel that clinically. You'll be able to tell exactly where it is, but we need to try and show that it is complete. And in this case, it is complete. The bone looks intact. There's no bone bruising. There's no fracture of the bone. So it hasn't pulled off a bit of bone. It's just the tendon itself. So the surgeon needs to try and bring that tendon all the way back down and reattach it. You can get other conditions around the distal biceps. You can get a bursitis, and these are rice bodies in a patient with rheumatoid arthritis, joint effusion, and then these little rice bodies, synovitis, in that fluid around the tendon. So it's a tenosynovitis of the biceps distal tendon. Okay, so we can actually see the nerves around the elbow joint quite clearly. We can usually identify them. So on the median nerve here in yellow arrows, shown here on the surface medially, and then we watch it coming down more distally there and there. It's quite, you find it above the elbow joint, and then you can follow it down. Make sure it remains iso signal to muscle, same signal as muscle. Make sure it's not enlarged, make sure it's not discontinuous, make sure it's not particularly compressed. I mean, that it's not one that it gets easily compressed there in between two muscles. And then on the radial side, you'll see the radial nerve in there again. And again, it should be easily identifiable. You follow it down on your axial images. And then the ulnar nerve is the most commonly damaged, or it can sublux. And if you do, sometimes you'll see it just not in the ulnar groove behind the humerus. It'll be sitting out here somewhere where it can be stretched. It should be an even size, cross-sectional size, as we follow it down. The signal should not be high within it on T2 or stir images. And there should be no compressive lesions in the ulnar groove. I've got a couple of examples to show you what lesions could be there. I've shown you the osteophyte already. Here's a sort of enlarged view of the ulnar groove. So posterior band of the ulnar collateral ligament forms the floor. The ulnar nerve is this structure here, looks a little bit grey on this picture. There's a retinaculum overlying it, holding it in place, and that's just sort of like a diagrammatic representation of this ulnar groove. I've shown you an osteophyte, but you can get an accessory anconeus muscle. Normally the anconeus muscle is on the other side, but you can get an accessory muscle. So that acts like a space-occupying lesion, something that shouldn't be there, which then compresses the ulnar nerve. So where it's compressed, you should see reduction of the cross-section area, flattening of the nerve, and just above it you may see a thickening, and there would be, on T2 or stir images, there would be increased signal inside it, and you can then follow that down. And if you see that, then the surgeon may often go and cut that muscle attachment or remove it to stop it pressing on the ulnar groove. If it's subluxing, he may try and stitch it in place so it doesn't bob in and out. Obviously, it needs to be put somewhere where it's not going to be constantly traumatized. Okay, so that's the elbow. Any questions, comments before I go on to the wrist? Is it too much? There's a lot of little structures in there around the elbow, so it does take a little revision of your anatomy. Shall I go on? Any comments? Was that too fast? Yeah. Okay. Okay. So look at the wrist then. So similarly, you need to assess the wrist MRI in a structured fashion to not miss something, not miss abnormalities. So again, we start with alignment. We start with any fluid. How much fluid is in there? Is it abnormal? And then in the wrist, there are lots and lots of ligaments in between the carpal bones, the intrinsic ligaments. Look at the ulnar side, look at the extensor compartment, flexor compartment, look at the articular surfaces, and then look at the extrinsic ligaments. So that means those attaching from the distal forearm bones, radius and ulnar, onto the wrist. Look at what the bones are looking like and surrounding muscles and blood vessels, etc. Ooh. Okay. So, alignment first of all. So on coronal view, there's something called the arcs of Gilula. There are 3 of them there shown in 3 different colors. Basically, the carpal bone should be in congruity, so they should be in this sort of arc fashion. And the other fact to remember on any imaging of joints is that joint spaces should be even throughout the joint. You can't have a widened joint space on one side and a narrow joint space on the other. Similarly, all these intercarpal spaces should be basically the same width. You shouldn't get a particular widening in any of them. Then looking at the scaphoid and lunate, that's one of the commonest injuries, the scapholunate intrinsic ligaments, the attachments between those two bones. Scaphoid lunate. If these ligaments are torn, then you'll get abnormal separation or subluxation of these bones, which can give you, even without a fracture, can give you painful wrist after an injury, or which is difficult to diagnose otherwise. So if you draw a line on the across the dorsal surface, I think that is, of the scaphoid and lunate bones, then the scaphoid should not project over that line. So in other words, you shouldn't get a wonky line. It should be a nice straight line on the dorsal surface between those two bones. And then the third place to look at alignment, look at your sagittal view, or on an X-ray that would be your lateral view. And the lunate proximal articular surface should be congruent, in other words, parallel, should be articulating with the radial articular surface. So we should see those two nice and parallel. So that arc there. And then the distal surface of the lunate should be congruent or parallel to the capitate proximal articular surface. So that arc there should be. So on sagittal view, just check those two, because we have injuries that we might spot in those areas. And then the next thing that you can look at the ulnar variance, or the ulnar length. Basically, this surface of the ulna here should be in line with this. That's our arc of Gilula. And this ulna here is short. It's probably 2 or 3 millimeters shorter than it should be. And this ulna seems 2 or 3, not centimeters, millimeters, sorry, should be the same arc of Gilula, but it's 2 or 3 millimeters longer than it should be. So this is called negative ulnar variance, which is associated with avascular necrosis of the lunate, Kienbock's disease. And this is called positive ulnar variance, where this abuts on that, bangs on that in different positions of the wrist. And you can see marrow edema because of that in the lunate, and you often see it on the ulnar side as well. And that will cause injuries of the triangular fibrocartilage, which is this dark structure here. I'll show you examples of that in a minute, but it can cause damage to that triangular fibrocartilage. And this is evidence of ulnar abutment syndrome. A patient may present just with wrist pain, and it's difficult to diagnose why they've got wrist pain. Do you know how you treat that? Or how does a surgeon treat that? I heard somebody whisper it. They have to shorten the ulna. So it's not undertaken lightly, but somewhere in the shaft, they will do an osteotomy, take a bit out, and then join it back together again with a pin and plate. And then basically making the ulna shorter. So you don't get this constant trauma here. And that should allow the wrist pain to settle. So quite important to spot that. Then the distal radial ulnar joint, you want to make sure this articular surface is congruent, is parallel to that radial articular surface. How do we do that? We draw a line between the two dorsal corners of the ulna, and you get that line, and then on the volar surface. So the ulna should remain within that space between these two lines, or no more than 10 to 20% outside it, front and back. So this one's at least 50% out. So that's a subluxation, a dorsal subluxation. And that's an example on MRI of subluxation. just a diagrammatic representation of all the various ligaments. There are lots of them. So, and in a good scan, you actually can identify most of these, or all of these, usually. The commonest ones will be, though, the scapholunate ligaments, which are injured. The intrinsic ligaments are the ones in between all the carpal bones, and the extrinsic ligaments are the ones that attach to the radius and ulna and then to the carpal bones. So on a coronal image slice, this little dark structure here is the scapholunate ligament. This little dark structure here, usually triangular, is a lunotriquetral ligament. And on an axial view through the scapholunate ligament, you should see a dorsal and a volar surface, ligament. So there's one there and there's one there. And you need to try and assess both of those and make sure they're intact. And what happens if they're not intact? Well, you get this widening, this separation. Look, all the other joint spaces are a certain width, but this one is much, much wider, isn't it? So that's abnormal, and it's because that ligament that holds these two bones together, the scapholunate ligament, is torn. And with this separation, this is probably 3 or 4 or 5 millimeters, with this much separation, probably both the dorsal and volar scapholunate ligaments have been torn. So this used to be called or is called I would know it as the Terry Thomas sign, but that's revealing my age. I don't know how many of you know who Terry Thomas was? Okay. So the youngest member of the group, do you know what Terry Thomas sign? Who was Terry Thomas? That fella? Well, but who was he? He's a comedian actor. Okay. So, rather inappropriately perhaps, or not PC, maybe we should rename it the Kemi Badenoch sign, but I'm moving rapidly on. Okay, so the dorsal and volar intercalated segmental instability, so that's instability within the carpal bones, between the proximal and distal rows. So the lunate bone here, you remember that diagram? It should be congruent on both the radial and the capitate sides. And the lunate should be fairly horizontal. Here it's leaning backwards, can you see? That surface is sort of pointing backwards there. And here it's pointing forwards like so. So these are both unstable instability of the lunate, and that's it on an MRI scan, a nicer image. So you see how this lunate is pointing forwards. Is it pointing forward? No, that's backwards, isn't it? So that's a DC, and again, that's because the scapholunate ligament is torn. It's allowing the lunate to sublux. And the next example is the volar one. Sorry, the wrist is the other way around, but there's a fracture of the radius which is which is caused as part of the injury, scapholunate ligament injury, and that's allowing this lunate to tilt forwards. And then the third lunate instability is when it should look like that on a sagittal view, lunate articulating the radius and capitate, and it's relatively flat. But the lunate can dislocate completely. So that's a lunate dislocation. So it's no longer congruent with the radius or with the capitate. So that's obviously a lunate injury. It's not a radius or a capitate injury. Whereas here, the lunate is still congruent with the radius, but it's not congruent with the capitate. So that's a perilunate dislocation. There's not a lunate injury. It's more a distal carpal row injury where it dislocates at that level, at the mid-carpal level. And that's an MR example of a lunate dislocation. So it's no longer articulating with the radius or with the capitate. it slipped out. And that clinically should be quite obvious. You'll see a bony lump where there shouldn't be one. And then how that would happen, it's usually some sort of a fallen outstretched hand, but it's pretty violent. Oh, they certainly could do, yeah. We saw that example with the radial fracture. Yeah, but if the lunate is dislocated, they'll be fixed. They won't be able to move their wrist particularly, and there'll be a big bony bulge at the front. So I think it'll be obvious even to the patient that there's something pretty dramatic happened. And hopefully they won't come to you in your next outpatient clinic. They'll have gone to emergency department straight away. Okay, triangular fibrocartilage of the wrist. So sits here in this fovea in the ulna. It's a fairly complex anatomical structure, but it's relatively simple appearance on the MRI, but anatomically, as this diagram shows, it's actually is quite a complex structure with different bands and ligaments contributing to it. It attaches to the radius on one side and to the ulnar styloid on the other side. The slight complication on MRI is that the radial articular surface goes in underneath here. So the triangular fibrocartilage actually attaches to the articular surface, and therefore I'll show you the example, but you can still see cartilage beneath it, and sometimes you can be fooled into thinking that there's a tear when there isn't one. So that's normal hyaline cartilage wrapping around the radius, and this darker structure is the triangular fibrocartilage. So that is not a tear. That's normal. Oh, actually, I've called it a tear, haven't I? No, that must be that thing there. Sorry. That's normal. That's the perforation. So you've got a bit of triangular fibrocartilage on the radial side, normal hyaline cartilage, rest of the triangular fibrocartilage here. And on this example, the injury is on the ulnar side. So that's the ulnar styloid. This is the triangular fibrocartilage, and there's fluid trying to get in through here. So that's a perforation, a tear on the ulnar side. This one's on the radial side. Okay, so obviously we got lots of tendons around the wrist, and you can assess tendons really well with MRI and with ultrasound, by the way. So if you're specifically looking for a tendon, tenosynovitis, tendon tear, tendinopathy, then ultrasound's pretty good for superficial tendons. So around the wrist, it's pretty good. So it depends what you can get quicker and easier. So the extensor tendons, there are 6 compartments labeled 1 to 6 from the ulnar side onto the radial side, and then the flexor tendons on the other side. And they should all look dark, black, even thickness at a particular level. Here's an example of de Quervain's tenosynovitis, where the abductor pollicis longus, extensor pollicis brevis tendons here are on the radial side are thickened and are looking a little bit grey rather than black as these ones are. And there's also excess fluid in the tendon sheath. So this is a tenosynovitis, de Quervain's disease. I gave myself de Quervain's after the tsunami. I was off in the tsunami with an injury. And by the time I came back to work, there was a huge waiting list of prostate biopsies to do. And so I thought I would do some extra lists. So I was doing 3 lists a week to try and catch up of 6 to 8 patients a list. And you do 12 biopsies per patient. So there's a very strong spring-loaded needle, and the action to load the spring was cocking it like that with your thumb and then firing it with the same thumb. So those tendons were getting used 3 times a week, 12 times a patient, 6 to 8 times a list, and they got a bit of a hammering. And so I got the Cravains. I had to rest it and let it settle down. But if I do use that, I had to swap needles as well. I used a different needle now. But if I do use that needle within a couple of patients, I will know that it's hurting again. And that's the problem with tendonitis, isn't it? Once you've had it, you've got to be really careful not to keep getting recurrent problems. So here we're looking at the flexor compartment. So there's tenosynovitis around these two. So there's excess fluid. There's some grey stuff in the fluid. That's the synovitis. There's increased signal. That should be a nice black round tendon, but you've got some linear signal in there, possibly a longitudinal split tear in that tendon there. Okay, so a couple of examples of different wrist joint problems. So this one's rheumatoid arthritis. You've got some erosive changes, cystic changes in the scaphoid here. You've got joint effusion. You've got grey stuff in the fluid. So that's synovitis. You've got some spotty marrow signal changes, marrow edema in here. And that patient had rheumatoid arthritis. So pretty bad wrist synovitis and arthritis. This patient had a more difficult diagnosis to make in any way apart from MRI, and we don't see this anymore because they've stopped using this. This patient had a silastic implant for a lunate. So the lunate presumably had been damaged. I don't know what the background was, but it might have been Kienbock's disease or trauma or something. So they'd taken the lunate out, but rather than leaving an empty space, the surgeon had put a little silastic implant, which is great anatomically. It fills the space and allows the articulation and all the rest of it. But what used to happen to them is little bits used to break off. And then there was very irritating to the normal tissues. So you'd get a synovitis, because you've got debris everywhere. So you get this very prolific synovial thickening, and then it would start eroding bone, and it would become a very, very painful, swollen wrist. Plain X-rays wouldn't really show you anything, and very difficult diagnosis to make. But it was the silastic implant, because you get bits of silicone flying around. So the only way to cure it is to take it out, get rid of the silastic implant, and it all settles down. But you shouldn't see that anymore. And then a couple of nerve injuries. So here is an axial view through the wrist joint. This is the carpal tunnel here. The dark structures are the tendons coming down, flexor tendons. And then this slightly brighter structure is the median nerve in the carpal tunnel. You can also see it on ultrasound. Carpal tunnel syndrome, very common, as you all know. That median nerve should be mobile. So particularly in ultrasound, you can put your probe across that and get that view, and then you can get the patient to make a fist and relax. And you should see the median nerve mobile inside that carpal tunnel. And it should still have this convex surface, flexor retinaculum over it. And it shouldn't look flattened. So in carpal tunnel syndrome, you may see it flattened, reduced cross-sectional area, and then slightly more proximally, it may be looking larger than it normally should, and with brighter signal in it. So that would give you carpal tunnel syndrome if the median nerve is compressed. And then just outside it here is it's called the Guyon's canal, and the ulnar nerve sits in there. And if there is something impinging on that, then you may get a Guyon's canal neuropathy. which so that is meant to be a compressed median nerve, so it looks rather flatter than you'd expect, nice and round. And then here, that's the carpal tunnel, and then more superficial to it, Guyon's canal should be sitting here, and you've got this big bright structure on T1 and T2 weighted images. Here it is in the sagittal plane, and here it is on two axial planes, and that's compressing the ulnar nerve in there and giving you Guyon's neuropathy. So Guyon's canal syndrome will affect the ring finger and the little finger, and carpal tunnel syndrome will affect the thumb, index, middle, and a little bit of the ring. So if you like, they're sort of opposite sides. Another cause may be a ganglion cyst for wrist pain, and this one's a big one. What's a ganglion cyst? It's just synovial fluid, possibly coming out of a joint, so wrist joint, one of the intercarpal joints, or it can also arise from a tendon sheath. It can feel very hard. Quite often we see requests saying bony hard lump. What is it? But it's a ganglion cyst. It's not a bone, but it can feel very hard because it's under tension. It's fluid that's under marked tension. And this one's a big one, so this one's not going to be, you're going to see that and feel that. But sometimes they're occult, they're tiny little ganglion cysts, which we'll find with MRI, but you may not have felt them, but the patient's complaining of pain. So the surgeon would go in and resect. Theoretically, you can stick a needle in it and aspirate it, but it's synovial fluid, and as you know, that's very viscous, very thick. You're not going to get it up a needle. Almost no matter what size needle you use. Sometimes you can just, if it's a tiny one, you may disrupt it with a big fat needle, but the patient's probably not going to thank you because it'll come back. And that's the one in the good old days, they used to tell you whack it with a family Bible. Don't do it. A, it hurts, B, it'll come back. So it won't help, no matter how religious you are. Okay. Another tendon abnormality, pigmented villonodular synovitis. PVNS is the old name, but it's apparently now called a diffuse tenosynovial giant cell tumor. Giant cell tumor of the tendon sheath was an alternative old name, but apparently it's now the correct name for it is diffuse tenosynovial giant cell tumor. So it's basically synovitis in a tendon sheath. So you get fluid, you get synovial hypertrophy, big lumps of synovium. But why is it pigmented? Because you get bleeding into it. So if a surgeon cuts it open, he'll see colors. It's pigmented because of the hemoglobin breakdown products. And hemoglobin contains iron. So when hemoglobin breaks down, iron is free in the tissues. If iron is there, you know MRI, we don't like iron because it causes artifact. So these little black blobs are iron deposits, and you get flare on MRI. So if you get synovitis with flare in it, black blobs flaring, looking bigger on certain sequences than others, then we know there's been bleeding. And the typical synovitis which bleeds is pigmented villonodular synovitis, PVNS. It can be erosive, it can erode bone. The treatment is to resect, try and do a synovectomy, try and strip out all the synovium surgically. But it can recur. It's a benign condition, but it can recur. And it can cause bone damage, and it's usually one joint or near one joint that the patient gets it. It's not a diffuse, it's not a systemic condition. Patients who get it in large joints may come to joint replacement eventually because there's a limit on how often the surgeon can do a synovectomy. Okay, so any questions?